Olá, bem-vindos a mais uma sessão do ABR Entrevista. Meu nome é Marcel Menon-Miak e hoje eu vou entrevistar o Dr. Benjamin Bleier, do Massachusetts Eye Infirmary da Harvard Medical School em Boston, nos Estados Unidos, e que foi o autor do primeiro estudo a avaliar a segurança e o potencial de aerossolização de exames endoscópicos nasais e da cirurgia endonasal. O título do artigo, traduzido para o português, é Instrumentação endonasal e risco de aerossolização na era do Covid-19, simulação, revisão de literatura e estratégias propostas para minimização. Hello, Dr. Bleier. Thank you so much for accepting our invitation. It's a great honor to have you speaking for us. And before we talk about your study, how's the COVID-19 outbreak in Boston? Are you still at the top of the curve of cases, or is the population already returning to their normal activities?
Well, first of all, Marcel, it's great to see you. For those of you who don't know, Marcel spent some time with us in Boston and was one of our very best international fellows. So it's great and an honor to be here speaking with you and the society. With respect to Boston, right now we've peaked over the past 1 to 1.5 weeks. We're starting to see the curve drop, but very slowly. We're also starting to open up the sort of society a bit in a very phased approach. So we have to see how that goes with respect to whether infection rates go up during that time.
All right. So in Brazil, there's an anxiety among doctors because there are high rates of infection, specifically among otolaryngologists. And your study was the very first to describe the aerosolization risk in endonasal instrumentation and give us some orientation. Could you tell us the background of the study? What did you have in mind when you planned it? And feel free to start showing some of the slides you have.
Yeah, so let me bring up my slides here. So I'm going to share my screen because I think that'll go over sort of why we undertook this study in the first place and give you a little bit of background. Can you see my slides there?
Perfect.
Okay. So as always, I just want to present my disclosures here, including the fact that we are working on some design solutions to improve some of the risks that we'll be talking about. So the reason that we undertook this study was, as everybody, once we started hearing news reports regarding this infection in China that was spreading and starting to come around to outside the borders of China, there was already reports starting to come out which were very worrisome, specifically to healthcare providers and then specifically to otolaryngologists. And I sort of, if you put together the timeline and the types of things we saw, it actually goes back to even before the SARS-CoV-2 pandemic, back to studies on SARS-CoV in 2010, which demonstrated that there was a dose response to the severity of the infection based on exposure. So already from a healthcare provider standpoint, there's an elevated concern because in theory, we could be exposed to high doses in actively infected patients. So as we all know, in the end of December, the SARS-CoV-2 infection started to release reports emerged in China, although now it seems they may have started even earlier. Then in February, there was a report that there were elevated viral titers in both the nose and nasopharynx. And this was actually the basis for why testing started out by doing nasal and nasopharyngeal swabs. So again, very specific to our field. And then in mid-March, this was declared a pandemic by the WHO. Only a week later did we have the first report that the virus was not only present in the nose and nasopharynx, but also potentially could have airborne transmission and could remain in air for several hours, which again is concerning particularly in the healthcare environment. And then around the same time, we started hearing reports, at least in news reports, that there were high infectious rates in otolaryngologists in China, but also in ophthalmologists. We'll talk a little bit more about that. But you can see all this data coalescing around a high risk, particularly in the ENT space. And then at the end of March, there was starting to be some of these anecdotal reports, and in particular, a report of a pituitary surgery in China, where at least at the time it was reported that the patient was positive and the entire OR team became infected. Now, subsequent to that, it turns out that that wasn't the case and that the infections were actually not among the OR team, but among the pre and post-operative staff. But you can see that there was a lot of anxiety. And in all of this, as I started to read these reports and started to see blog posts and people talking about their anxiety and how they were going to manage things, it became clear that none of us really knew what the issues were. We were, as a field, not very familiar with the concepts of aerosolization and the risks associated with it. And so that was really the basis for the initial study, was to just essentially get a handle on the data, on the information, and codify the literature so that we could then develop some evidence-based approaches to understand our own risk. So what I'd like to do is talk a little bit about what we found, both from an informational standpoint and then some of our data. And Marcel, feel free to stop me with questions at any time. So when we think about what aerosols are, these are small particles that are generated by airflow over an air-liquid interface. The size of the particle is proportional to airspeed. So more rapid airflow produces smaller particles, which will tend to be more airborne. And as a correlate, the transmission distance is inversely proportional to particle size. So that's why larger particles will tend to settle, while smaller particles will tend to float. So if we take very broad characterization, we can see that when we think about direct droplet transmission, these are particles that are around 100 microns, can be about 30 to 100 microns, and these travel less than a meter, or in the US, we think about this about less than 6 feet. And this is why we, in our social distancing guidelines, everyone talks about staying 6 feet away from each other, because the idea here is to reduce droplet transmission, which has been well established in this disease. Now, airborne transmission occurs among particles much smaller. These are less than 10 micron particles that are called droplet nuclei. And these can remain in air, they can float on air currents and diffuse throughout an enclosed space. And if the virus is capable of transmitting in this fashion, that could be concerning, because these will travel much farther than that 1 meter or 6 feet. It's also important to understand that the size cutoffs is a spectrum. It is certainly not a binary system. And in fact, medium to larger size particles, for example, 20 micron particles, as they float in air, they can evaporate and desiccate into these smaller airborne particles. So this is just a general guideline. Now, when we think about where aerosols are generated, there's quite a bit of literature on this, not in the otolaryngologic literature, but in the infectious disease and pulmonary literature. And it turns out that physiologic aerosols are generated deep in the distal respiratory bronchioles, these very small bronchioles just before the alveoli. And they actually produce the aerosols during the inhalation phase. As these airways open up, and they pop open, and that velocity of opening generates aerosols within the lumen of those bronchioles. And that's why many reports now have confirmed that normal breathing and even speech produces more aerosols than even coughing, because that recruits more of these respiratory bronchioles. And it has been shown that in cough and sneeze events, particles between 1 to 500 microns are produced. So this is all the way from the airborne range all the way through the large droplet range, although the majority are over 8 microns. And so when we think about airborne transmission, again, we're now narrowing down into a very small category of particles. And these are particles that are transmitted through these droplet nuclei. These are, again, less than 10 microns, and they're inhaled and deposited into the lungs. So they tend to bypass, for the most part, the upper airway. And when we think about the infectious transmission, there are several types of airborne transmission. There are pathogens that are obligate airborne transmissible pathogens that require these airborne droplet nuclei. So this is something like tuberculosis. Then there are the preferentials, which prefer airborne transmission but can use direct transmission, such as measles. And then finally, there are the opportunistics, which prefer direct transmission, like the droplets that we discussed, but they can utilize airborne transmission. And that was shown in the original SARS-CoV infections. And we think that's maybe happening in SARS-CoV-2. But specifically for healthcare workers, we have this concept of aerosol generating procedures. And these are procedures that are performed in a medical setting that create conditions favorable for the production of airborne particles and then the subsequent transmission of those particles. And the concept here is that these procedures are things that may not be encountered in the community, but are specifically occurring in the healthcare setting to increase the risk of airborne and opportunistic transmission. And so it was really in the background of that understanding that we then undertook our first of now two studies to look at the aerosolization risk. And so this study was first published online back in April 3rd. And here we were really looking at particles in the droplet range. And this was a very a study that we put together very quickly. So we realized that we didn't have the instrumentation with the sensitivity to look at the airborne particle range. So we wanted to at least start by looking at the droplet particles. And what we did was we divided the study into two phases. Into a clinical phase to mimic procedures we would be doing in the outpatient setting, and then the surgical phase. And there's a good reason for that differentiation. But I just want to go through very quickly the data. And then what I want to do is at the end of showing the droplet data, I'm then going to bring in our new data, which was published online in the White Journal last week, which now brings in some of the airborne size particles as well. And so in our initial study, a cadaveric model where we had this grid in front of it, and we mimicked an outpatient sneeze condition by putting an atomizer in the nose, which is known to produce particles between 30 and 100 microns. And we labeled it with fluorescein and then used a blue light filter to pick up both the distance the particles traveled and their size. And then we also thought about using a mitigation strategy, knowing that the literature suggests that surgical masks are effective in droplet prevention. Could we develop a very easy mechanism to perform endoscopy while protecting the provider from droplets? And that really was the genesis of this concept of the vent mask, which is, and I know, Marcel, you're going to be putting out a video at some point to show how to make these. But the idea here is, how can we make a protective mask using only supplies that are common in any clinic? And so here what we did was we took the finger of a glove, we cut it off with some extra extension into the palm and draped it over the front and the back of a surgical mask. We then put 4 staples to create a seal, and now we have 3 layers of material. We have the 2 gloves and then the mask intervening. And then with a small puncture, we're able to pass a scope through while the gloves retain a relative airtight and watertight seal around the scope. And so we looked at those conditions, and what we found was favorable with respect to the mask conditions. And so what we see here is that with no mask, on the y-axis, we see particle diameter, and on the x-axis, we see distance from the nose. And so if the subject does not wear a mask, or the mask has a hole in it and no glove, and we simulate a sneeze, we see significant spread, which is ameliorated by the mask or the vent mask condition. And we saw this both by the total surface area affected and the droplet size. And so semi-quantitatively, you can see this as basically, this is the grid in black, and the gray boxes are where we saw contaminated droplets. You can see that wearing a surgical mask really prevented contamination, as did the vent mask. However, in the no mask and perforated mask conditions, you can see that a simulated sneeze using the atomizer really spread droplets throughout this area, just in the same area where a provider would be standing. Now, this is the data for droplets. And again, we then went back with our second study to then look at the risk in similar conditions using for airborne particles. The other big difference in our second study was that for the clinical conditions, we used live subjects, not a cadaver. So much more appropriate and germane to what we would experience in clinic. And so in this case, we used a particle detector, which was able to detect particles at about 15 centimeters from the nose. And we mimicked a variety of conditions that we would think we would encounter in an outpatient diagnostic setting. So things like heavy breathing or panting, coughing, nasal endoscopy, speech, and then sneezing. And on the y-axis here are the number of particles generated over about a 30-second interval. And what you can see is that while panting and coughing did generate particles, these were not statistically significantly above the baseline particulates in the room. But performing nasal endoscopy, either flex or rigid, started to generate statistically significant airborne aerosols, speech even more so, and we'll get to some details on that later. And then finally, sneeze was an order of magnitude higher, which is, again, is expected. So we then took our surgical vent mask concept and said, well, now with airborne particles, how can we similarly mitigate this? And what we found was a little bit disconcerting with respect to our droplet findings. And that was that when we used an N95 mask or an N95 with a vent modification, we were able to ameliorate or drop those airborne aerosols down to nothing above background detectable range. Also, note, when we had the subject talk or sneeze into the mask and then remove it in the room, we actually saw particles escape from the mask. And what that tells us is that particles are trapped inside the mask for an N95. And so if you're going to use that as a control method, you don't want the patient to remove that in the room. You want them to leave the clinic space before they remove it. Now, when we checked the surgical mask, and this wasn't even with a vent modification, this was just the surgical mask with a simulated sneeze. Unfortunately, we did see a significant escape of airborne aerosols. And I think what this tells us is that the vent mask is very good to control droplets, but not airborne particles. Really only an N95 that's fitted is capable of doing that. Comparing that to the no mask condition with a sneeze, we basically see significant release, which was similar to this. And then finally, we also wanted to see what type of aerosol production we would get with a common topical atomizer, where we would use this for nasal decongestion and anesthesia. And this actually produced more aerosols than even sneezing. And so unfortunately, the behavior we're most concerned about, which is sneezing, the best way to mitigate that, we know, is decongestants and anesthetics, but our traditional methods are somewhat limited because they themselves produce aerosols. Now, we then went on in both studies to look at the surgical conditions. This reason we split this up is because surgical aerosols are a completely different animal than clinical physiologic aerosols. As we discussed, physiologic aerosols are generated in the lower distal respiratory bronchioles. But in a surgical setting, at least under general anesthesia, there's an endotracheal tube and a cuff up, which means that the lower airway is actually excluded. And what that means is that the aerosols that we're interested in during surgery are really those produced by the instruments. So we really have to focus on the instrumentation when we talk about surgical aerosols, which is very different than the physiologic aerosols that the patient is producing in an awake clinic setting. Now, there actually is a reasonable amount of literature that covers the surgical risks of aerosolization, and largely comes out of the orthopedic literature. And so again, as I noted, the aerosolization is instrument dependent. And it is known, for example, that in thermal procedures, so electrocautery or laser, these produce high volumes of ultrafine particulates. Now, it is not necessarily known in all cases whether these particulates contain live virus, but suffice it to say, the risk in electrocautery is production of sort of these small particles in smoke. As we get into the cold-powered instrumentation, like drills and so forth, again, it's been shown in the orthopedic literature that high-speed drills certainly produce aerosols that are capable of contaminating an entire operative suite with, for example, a Staph aureus, can contaminate the surgeon, as you see in pictures like this, where you see fluorescent particles. And then finally, it has been shown that you can detect HIV in cold aerosols coming off drills. So we know that there is a risk here, and we certainly use all of these types of instruments in ENT procedures. And so in a similar vein with our setup, we started by looking at a microdebrider and a high-speed drill, first in the droplet category and then in the airborne. So with respect to droplets, what we found was very interesting. The cold instrumentation, so using hand-actuated instruments like through cuts and biters, as well as a suction microdebrider, did not generate detectable contamination for droplets. On the other hand, all the drill conditions we looked at, so whether we're drilling the nasal beak, as for example, doing a drill out procedure, drilling a sphenoid for like a skull-based procedure, or even removing the drill and just activating it outside the nose, all produce detectable droplets. Now, at the time, this was very commensurate with these reports coming out of China about these skull-based procedures causing infection. Now, again, those stories turned out to not be the case, but nevertheless, the risk, in fact, was there the whole time. Now, moving into the airborne side of things, and just to note that we were actually able to exacerbate or worsen droplet spread with when there was more fluid in the nose, and even just trying to occlude the nares didn't really reduce this. And so this is a real issue for us in surgery. But on the airborne side, again, we use the same setup as we discussed before. So we use this optical particle analyzer, which I failed to mention. It detects particles between less than 10 microns. And here, again, on the y-axis, we see number of particles generated, and on the x-axis, we see all of our conditions. And so when we're doing just open suctioning of the airway and with the microdebrider, again, no particles were detected, which really supports what we found with our droplet findings, that the microdebrider appears to be relatively safe with respect to airborne aerosol production. Interestingly, with our through biting condition, we did see some detectable aerosols, although again, this was not significantly above baseline. So hard to know what to make of this, but if you really think about the issues of aerosols being produced by high velocity motion, if you're using a through biter on a bone, at the moment through the bone, it actually picks up a fair velocity. So we think maybe that's why a very small number of aerosols are produced. But where we see significant aerosols is in essentially all the drill conditions and in the electrocautery conditions. And these aerosols are orders of magnitude more than what we see in clinic. So the risk really for surgery is with drilling and electrocautery for the most part. Now, when we look at the spread or the array of aerosol sizes, which is here on the x-axis between 1 and 10, and the number of particles on the y-axis, we can see that for all the drilling conditions, the particles were pretty evenly distributed with a slight predilection for the lower particle size. But what you can see with this curve is that clearly the cautery particulates really favor the ultrafine and fine particulate range at the low end, which again is consistent with the previous literature. Now, interestingly, we took the one of the conditions, which was a suction irrigating drill, and we wanted to see what the effect of suctioning simultaneous to drilling was. And over the first 2 minutes, you can see that when we apply suction, we actually do a pretty good job of reducing detectable aerosols relative to the same drill under no suction conditions. Now, over time, because this is the same drill as this, we still start to accumulate aerosols, which eventually made their way out of the nose. But this just goes to show you that similar to the microdebrider, having distal tip suction really helps to prevent that risk. And I think that's an important finding. So in conclusion, with respect to our experimental findings, if we summarize, what we found in clinic was that detectable aerosols were found during endoscopy, during speech, and certainly during sneeze, which is the highest risk behavior because it is associated with the highest concentration of the aerosols at the highest velocity and is by definition unpredictable. And as I mentioned, we are limited now with the types of topical anesthetics we can use, which makes the risk of sneezing even worse. On the operative side, again, the detectable aerosols were really clustered around all the drill conditions and electrocautery conditions, which predominantly produce finer particles. And so ultimately, when we talk about the risk of these quote unquote aerosol generating procedures, if you look at the CDC guidelines, the definition of an aerosol generating procedure is not very strict. They define it as a commonly performed medical procedure that creates uncontrolled respiratory secretions. But they also note that there is neither expert consensus nor sufficient reporting to create a definitive list, which basically means every subspecialty, including us, need to really take the risk that we see in our own experimental and clinical models and decide for ourselves what the risk is. And so while we can't really definitively say a procedure is a aerosol generating procedure or not, because that's really a local sort of policy type of decision, clearly nasal endoscopy does produce all of the risk factors associated with classic aerosol generating procedures, and I think requires the high level PPE that's associated with it. Now, just a word on speech. When we saw our outpatient data, what we saw was that while endoscopy did produce statistically significant airborne aerosols, it was actually slightly less, although not statistically different from the aerosols generated during speech. And you may interpret that to say that the number of aerosols are therefore not concerning. But I tend to look at it a different way based on the literature, in that speech in this situation actually is a concerning behavior. Let's go through the data. First of all, we've already discussed the fact that speech produces more aerosols than even cough. Our data shows that, and this is supported by previous literature, and that goes back to how aerosols are physiologically generated. In fact, epidemiologically, it's been shown that speech alone is capable of transmitting influenza. And we've already seen reports of high infection rates, as I mentioned before, of ENTs and ophthalmologists in China. And Marcel, I'd be interested to hear your take on the infection rate in Brazil. But we asked ourselves, why would ophthalmologists be infected more? And my guess is that if you're very close to a patient's face doing an eye exam and you're not protected and you don't know that there may be have an asymptomatic positivity, then you are exposing yourself to speech related aerosols. Also, with other epidemiologic studies, it's been shown that outbreaks have been associated with patients who were not touching other people who became infected. So for example, there was a famous outbreak in China where a infected patient was able to infect people throughout a restaurant up to 15 feet away. Now, this was in the setting of an air conditioning airflow. So you might say that the airflow, allowed droplets to travel, but not, suffice it to say, this patient zero in this case was largely speaking and was certainly not directly touching these other people. And then I think in the most well-characterized study, there was a famous epidemiologic incident with the Skagit Valley Choir on March 6th, where this was a choir practice that was undertaken by 60 people. Somebody or multiple people were infected before the choir practice, and after 2.5 hours, 45 people became infected and 2 died. Now, interestingly, this practice occurred after the pandemic had been declared. So these people were aware of the risk of infection. This was actually in Washington State, which was one of the higher and first affected areas. So they specifically did not touch or contact each other. And yet, just by singing in proximity to each other in an enclosed space, this significant level of infection occurred. So again, speech and breathing generated aerosols, I think, are risky. And as we also showed, if you're in a patient room and the patient takes off their mask, so let's say you're talking with a patient, you take a history, and then you move up to the patient and you start your endoscopic exam or your oral exam and you have them remove their mask, well, all those aerosols now become expressed into the room while you're standing next to the patient. So again, I think we have to really be cognizant that speech in this case can be a dangerous behavior, even though we may not think of it as such. And so now when we think about taking all of these lessons and understanding that we have to take care of our patients, we have to safely get patients back into the clinic, we have to really have an understanding of the basic parameters of infection control and mitigation that we have to implement. And you see lots of people talking about lots of different methodologies, but I like to sort of take a step back and think of it more categorically. And so it's important to start with understanding some very basic definitions, and these are all provided by the CDC. So the first is this concept of source control. So source control is anything that prevents an infected patient from expressing particulates or aerosols into the environment. And so a good example of this is a surgical mask. Now, an engineering control, on the other hand, is something that shields the healthcare provider or other patients from infected individuals. So a source control can be an engineering control depending on whose perspective you're looking at. But other examples of engineering controls are physical barriers or partitions between patients and air handling systems that change over air in a room. And then finally, there are environmental controls. And these are basically controls that clean the surfaces and all the high contact areas and the non-disposable instruments that you use. And those are also a very important piece of general infection control mitigation. And so in the setting of the fact that as of right now, testing is, in my opinion, not very reliable, not very available, and the turnover rates are relatively slow, we really have to adopt a posture of universal standard precautions. And this is defined as the assumption that every person that we treat is potentially infected or colonized with a pathogen that could be transmitted. And that's important because they may have virus on their person or on their clothing or on their bags. And that also has to be taken into account because of the infectivity of the virus from a contact perspective. And so the other thing to remember with universal standard precautions is it goes both ways. Because yes, we need to protect ourselves from the potentially infected patient, but as providers and as our entire provider team, we also may be asymptomatically infected and have to protect the patients from us. So we really have to think about not only these protective methods, but also the sort of bi-directional aspect. And so the way to sort of think about this is what I like to talk about are the 3 Ps. So the first is the patient. So we have to protect ourselves from aerosols generated by the patient, but we have to protect the patient from aerosols generated by us, by the healthcare team, and by the last patient who utilized that room. We then have to think about the provider, and the same rules apply. We have to protect ourselves from the patient and the last patient in the room, and we have to protect the patients from us. And then finally, we have to think about the physical plant, and that really is the clinic space itself. And so that's not only the instrumentation and the surfaces, but also the air, because obviously, as we've talked about with aerosol generating procedures in the healthcare environment, particularly with endoscopy, we have to consider that the air itself may be a carrier. And so when we think about control, ideally we want something that really sits at the nexus of all three of these, that can simultaneously protect all three Ps. And that's really the ultimate goal of mitigation in the absence of perfect testing opportunities. And so when we think about this more in a tabular setting, if we think about various solutions, we've talked about the vent mask with a surgical mask. So this would be considered both a source and engineering control. It works well for droplets, which is what D stands for, in diagnostic endoscopies. But endonasal procedures, and in this case, I mean both clinic procedures and surgical procedures, I don't think it's an adequate solution because A, you can't use bimanual instrumentation, you can't do active debridements, you can't remove packs with it on. And what does it do? Well, it does protect the patient from droplets from the provider. It protects the provider from droplets from the patient, and it protects the airspace and physical plant from droplets as well. But you can see there's a lot of gaps because it protects nobody from airborne particulates. Now, the N95 vent mask is a step up. Why? It's also both a source and engineering control. It protects both droplet and airborne particulates during and diagnostic procedures, but again, falls short in any interventional procedures because again, all you're able to do is pass a single scope through. Once you start really getting into procedures that require manipulation, I think this is not an ideal solution. But it does protect all three of these Ps from both droplet and aerosols. So it does a pretty good job, particularly on the diagnostic side. How about provider PPE, which I would advocate for anyone who's doing these procedures? Well, that includes an N95 or equivalent mask, goggles and eye protection, gown, and gloves. And so this would really be considered an engineering control from the perspective of the provider. It does a good job of protecting you from droplets and aerosols during diagnostic or procedures, but it really doesn't protect the patient at all from you or the last patient in the room. And so again, it protects the provider, but also doesn't really protect the physical plant because the patient can still be coughing into the environment or sneezing into the environment, and that's not protected using provider PPE. How about air changes per hour? So this is something that's really important for your clinic space when you're producing airborne aerosols. So again, this really is to do with your HVAC system and filtration. And it's a little bit beyond the scope of this talk to get into the number of air exchanges and how long to rest the room, although all that information is available on the CDC website. But this is sort of the classic engineering control. It does protect the patient, provider, and physical plant from airborne particulates after adequate exchanges have occurred. But notice it doesn't protect during any procedure, right? This really happens after the patient leaves the room because it takes 20 minutes, 30 minutes, up to an hour. So this really doesn't protect during the visit or during the procedures. It really only protects the cleaning of the room subsequent. So what do we think of as an idealized control? Well, it's something that acts as both a source and engineering control, protects against droplets and aerosols in both the diagnostic and interventional setting, and protects all three stakeholders in any clinic setting. And that's the types of things that we need to work towards. But one thing I would note is that none of these protect against or would be considered environmental controls. All of these types of controls still have to be used in conjunction with normal surface cleaning and instrument turnover to adequately protect the surfaces of both the waiting room and the clinic. And I think that's important, is that any idealized control from a source and engineering perspective is married with ideal environmental controls to give you that full picture. So thank you very much. I'm going to stop sharing my screen now, and then Marcel, I'm happy to take any questions.
Thank you so much, Dr. Bleier. Great lecture, great speech, great studies. And I have to say that I'm a little worried about the electrocauterization, all the aerosolization it produces, because a drill we can avoid in most of the emergency surgeries at least, but cauterization we use in almost every nasal surgery, right? Is there any strategy that you would suggest to mitigate this aerosolization from the cauterization?
Yeah, a great point, and I agree with you fully. Right now, we're working on strategies. I don't think there's anything that's definitive. What I would say is that, first of all, an important distinction to make between our studies and true infection is that our studies did not look at viral load within those particulates, nor even if you could detect viral RNA by RT-PCR, we didn't look at infectivity of those. So those are still open questions, but I think in the absence of data, we have to assume that there's a risk. And I think at the end of the day, the best way to do it is just to use the same PPE, the N95 or equivalent masks. Now we have to remember that what an N95 is a mask that is very effective at restricting particulates in the airborne range. So what it's rated for are 0.3 micron particles. So it protects you against 95% of those 0.3 micron particles. 0.3 microns, the reason that's used is sort of a magic size that has the optimal aerodynamic characteristics to kind of traverse through the various fibers in an N95 mask. Now, what we saw is that most of those particulates, or at least many that we saw, were still between 1 and 5 microns. So I think at the end of the day, the number of 0.3 micron particulates during cautery is still relatively low. So, I think the first thing is making sure you're just wearing proper PPE, using as much suction as you can. So suction cautery, I think if you can avoid things like bipolar or have a second person suctioning for you, I think those things for now are the best thing you can do. Certainly, I think more solutions are coming down the pipeline.
Okay. About the nasal endoscopic exams, I really liked your insight and I feel that the procedure itself, we can make it really safe with doing the N95 valve mask, but we really have to be worried about all the setup, like how the patients are putting and taking out the mask. Could you talk a little bit more about that?
Yeah, so I think first of all, I would also note that in our study, we used live subjects who had been fitted for the N95. And as you know, an N95 only works if you've been appropriately fitted for it, because the fibers the filtration efficiency can be as high as you want, but if there's a seal broken, then it's not going to work. So I think that that also is an open problem right now, which we're moving towards developing solutions for. I think that the best thing to do in the current setting is to make sure that you, as the provider, are adequately protected with the full PPE, and then implement all of those other engineering and environmental controls into the room. And right now, that's really the best thing that you can do. And so, for example, what we're doing up at Harvard Mass Eye here in Boston is essentially we're quote unquote resting the room for an hour in between uses. So we know what our air exchange rate is. We know how many air exchanges per hour we need to get the room to an acceptable level. We do all the surface cleaning. And that's what we're stuck with for the time being. So you're protecting, if you go back to those concepts, the provider is protected by provider PPE, and then the physical plant and the patient are protected by these engineering controls with air exchange and surface cleaning.
All right. Okay, Dr. Bleier, thank you so much for your lecture and all the alternatives you are producing to protect the otolaryngologists all over the world during this pandemic, and hope to see you soon in Brazil.
Very good. I can't wait to get down there after this is all over.
All right, see you. Thank you so much.
Okay, bye-bye.
Bye.